I acknowledge the traditional owners of the land and pay respect to elders past, present, and emerging. So the question everybody has is that why are the AMC exams really hard and what you can do about it? So what are your major fear for AMC exam? I do run an interactive section. I would like you to talk and don't worry about it. Whatever you stay here, we'll stay here. So what are your biggest fear about AMC examination?
The pattern of the exam,
Mm-hmm.
like
What about
it's a
that?
face to face. It's a
Mm-hmm.
face to face exam. We have never done such an exam previously.
Mm-hmm. Okay, what else? Any other issues? Pressure, yes. Language and cultural barriers, yeah. Anything else? Time constraints, yes. These are actually real things that we need to look at. So time constraints are a problem, pressure, language and cultural barriers. But of all of this, what is your biggest fear? What are you really afraid of for the MC exam? Grading the system, having a mental block, yeah. How to approach cases, yeah. The passing rate, the low passing rate, okay. So the first question for you, all of you, is that why does AMC have a low passing rate? Why do you think the passing rate is low? You all are qualified doctors from your respective country. So why is the passing rate low? There must be a reason why the rate is low, right? What is that? Have you ever wondered? No? Okay, so PLAB exam, if you actually publish the PLAB recalls, GMC may not even give you your license. They will actually cancel your result and then you have to go through the ethical board. So PLAB has very recalls online. And for AMC, you probably will find the recalls online. So PLAB without recalls, they have a 60% pass rate. AMC with recalls has a 20 to 30% pass rate, about that. Why would that be? Any idea? So most of the time, the recalls, if there is one single case, you can have 10 to 15 permutations. So the person who wrote the recall or the person who went through the exam would have had the permutation 1. And then you are looking at that, and then you go to the actual exam, you don't realize that the scenario has changed slightly, but you're not ready for it. So when you learn recall based, and that can be detrimental for you. I promise you, this is an easy exam, and this is my result. That's my name, and I got 12 out of 14 stations. And station 6, I failed very badly because I had an ECG. I teach ECG in one of the universities here. I know how to read an ECG. For whatever the reason, in that moment, my brain would not work for me to read an ECG. On that day, out of the 38 doctors, I'm the only one who would have failed the ECG. It was a normal ECG, and I diagnosed my patient with an MI. There's no way I would have passed that station. So I got a 3 for the history, and the rest of it was 6. But because it was a 3, I failed that. And this is my next case I failed, and I know I failed this because I made one clinical error. My patient she's an elderly primary gravida. She had chronic hypertension. She was already on methyl-dopa. And I said, we need to change the methyl-dopa in your postpartum period because it increases postpartum depression. It is correct. Only thing is that you already have to be depressed for you to get postpartum depression. So maybe I made a clinical error. Not maybe, I made a clinical error. That's the reason I failed. So this is doable. I studied 3 months and I worked really hard. I was working full time as a doctor. So I studied morning from 4:30 to 6:30. I cooked breakfast, lunch, sent my children to school, went to work, came back, studied, had a shower, then studied from 6:30 until 11:30. Most of the time I slept 4.5 hours and I studied because I could not have written this exam emotionally. It would have scarred me. I've never failed an exam in my life, so I wouldn't have recovered. That's what I felt personally. Plus, it was a big financial expense for me. I have 3 kids, and so you can't spend this money again and again and again. So I needed to pass in my first attempt, and I thought if I give my heart and soul to it, I should be able to get through. So time was all I had to give, and I gave the time, and I passed. All right, so what are we looking for today? So you need to understand the success and failure of the AMC exam. You need to understand the patterns and the examiner expectation, common pitfalls across the AMC exam, how to do a structured approach to common cases, and the practical strategies for your success. So what do you understand so far about the AMC exam success and failure? Apart from the fact that everybody tells you it's a very difficult exam, have you ever understood what the examiners are actually looking for? They're really not mean people. They're really nice people. They really want you to pass. So what are the examiners looking for? Does anyone know what the examiners are looking for? Any answer? Communication skills, yeah. Anything else? Competent, safe doctor. Approach to patients, specific knowledge. Safe doctor. The first priority is safe doctor. You are a safe doctor. That's what they're looking for. Which you are. Show the examiner you're safe. So most of the people that I have had, so I run mock exams in the weekend, and most of them, the first question they ask is, if the patient is sitting and talking to you, they'll ask to me, is my patient hemodynamically stable? If your patient isn't hemodynamically stable, how would they be sitting on the bed and talking to you? You see the problem? You have all these phrases that are redundant, so you don't need to ask, is my patient hemodynamically stable? If you're really worried about something, you can ask for the vitals or what exactly you're looking for. But is my patient hemodynamically stable is a very redundant question. So that is first thing. And when I talk about recognizing AMC patterns, what do you understand from that? So what does it mean by recognizing AMC pattern and examiner expectation? Anyone would like to talk about it? What are the patterns? No? Okay, so the pattern means if you have given the exam before, if this is your second or the third approach, you know when you stand outside the door where your scenario is written. So the pattern is that what exactly the scenario is asking you. What are they checking? So you need to learn to develop an analytical skill. So if the station tells you that a 13-year-old has been brought in by the mother, you need to ask yourself, why have they why have they given you a 13-year-old? Why not a 20? Why not a 30? Because each scenario is written with a specific reason. It's not random. There is something you ought to find in a 13-year-old. That is why they have given you a 13-year-old patient. So ask first. That is the pattern you need to look for. So the examiner's expectation is that you understood your patient's age and you've already had a differential diagnosis, 3 common differential diagnoses in your head, and you're looking for it. The pitfalls happen is that most of the times the doctors don't see. So they see 13-year-old brought in by mother, headache. Okay, this is psychogenic because MC has asked these questions before. Am I not right? Wouldn't that be your first thought? There we go. And there's the problem. Okay. So the success and failure, this exam doesn't test your intelligence. This exam tests your clinical reasoning. You do not fail this exam because you're not smart. You fail the exam because you do not meet the criteria to work as a safe doctor in Australia. Do you understand that? Do you get that? Yeah. The usual thing is the BIH and your all the other things, and that is a problem. We'll go through this in a second. So what's the Padlet? You should have access to Padlet. If not, I'll do it now again. Go through the Padlet and tell me all the things you can think of. So that's the link to the Padlet. It's in the comment box. Hopefully I have the Padlet somewhere there. Yeah. Okay. So you are going to duration of headache. Is the headache constant? Does it come and go? What triggers a headache? Family history. Red flags, low loss of weight, burning, blurring of vision, worse headache at night, early morning vomiting, headache, numbness, migraine, meningitis, cluster headache, sinusitis, medication overuse, period history, regular. All right, characteristics of pain, rule out differential diagnosis, including malignancy, migraine, tension, headache, infection. Okay. All right. Side of pain, intensity, quantity. Okay, migraine questions. All right. So when you saw a 13-year-old brought in by mother with a 2 weeks history, the first question I said you need to ask why a 13-year-old. So tell me why would a 13-year-old have that's good. TTI, trauma tumor infection. All right. The first thing the mother you need to ask is why has AMC given you a 13-year-old? Why not a 50-year-old? Why not a 20-year-old? Why did they specifically ask for 13-year-old? What is in 13-year-old that is common? Acne, yes. Anything else? What can happen at 13? Migraine, menstruation, okay. What else? Tumor, correct. Stress-related injuries, yeah. Yeah. Stress or anxiety, school or social stresses. Now, school, social stresses, and stress related, all of that. How did you come to that? So, hemorrhage, yes. How did you come to that? Because in the previous years, there were questions about the common theme was the psychogenic headache, right? Correct? Yeah. Intracranial hypertension. Anything else? So if you had not met this patient ever before, if you have not read any of the AMC cases in your life, this is the first time you are in the GP clinic. This mom is bringing you a 13-year-old child and the child has headache. What are your differential diagnoses in your head? Think of it. Take a minute. This is your new case. It has nothing to do with AMC. You're a GP in the GP practice. Mom brought in a 13-year-old to you. The child has 2 weeks history of headache. Now tell me the 3 top differential diagnosis that you have? You can write it in the chat or you can tell me. What do you think? Tension, psychogenic migraine, myopia, steady pressure. I like the myopia. That's actually a good one. Myopia tumor. Refractory direct correct. Infection, brain tumor, SCP, meningitis, psychogenic. I would rule out first red flags. Okay, meningitis, migraine, tumor. Correct. So meningitis may not be the first one you need to rule out because if it is 2 weeks history of meningitis, is unlikely. So I'm happy to look at migraine. I'm happy to look at tumor. I'm happy to look at myopia. And the last in the list would be that the social pressures the child might have. But you see how we need to modify our scenario according to the actual patient present in front of you. Ignore all of the previous aims and recalls. If we can do that, you will pass the exam. That is what I did. So this is how I approached my case. I considered myself to be a new doctor in a hospital, and I have 20 patients that I need to take care of. And each patient, I'm seeing them for the first time. And then when I came to the rest station, I told myself, they got discharged. So I only have one less patient now. And that is how I mentally prepared myself. And I had a student who did differently. She said every station, she took it as her pilot. And she said, okay, that's a pilot. And she go to the next station, she says, oh, that's a pilot. And that works too. So whatever works for you, pick that. You are a qualified doctor, and I need you to believe that. Show the examiner you're qualified, you're competent, you're a safe doctor. So why do good doctors fail? So basically, you're not understanding the difference between knowledge and reasoning. MC clinical examination is not checking your clinical knowledge. It is actually checking your clinical reasoning capacity. You also need to have very solid time management skills. So I have to drive an hour and a half to work every morning. So I played this game, peekaboo. So I look at the clock on the car, and then I would check the time, and then I would say, okay, 3 minutes. Now it's 3 minutes, and I look back again. If it is 3 minutes, I won that. Then I would check 5 minutes. So I mentally prepared myself for the time, so I have an approximate idea of the duration. So I never ran out of time. And that was important for me to pass the exam. So in one of the stations, I had gender dysphoria case. I finished the station in 6 minutes. I know I finished in 6 minutes because the examiner told me I have 2 more minutes. And he asked me, is there anything else you would need to do? And I remember thinking, oh God, I'm going to fail the station because I have 2 minutes to spare. So I actually got 6, 7, 7, and 7 for my gender dysphoria case. So even if you finish early, don't panic. So remember that you need to look at the clinical reasoning and not the clinical knowledge. You show them that you're safe, you should pass the exam. Am I making any sense? Do you understand what I'm talking? I hope.
Yes, doctor.
Thank you. All right. So first priority for you as an international medical graduate taking your OSCE exam is that patient safety is your priority. Now, you need to remember something about simulated patients. The simulated patients are doing their job. They have been hired to play a particular role, and they have to be the same standardized patient for every single doctor sitting the exam on that day. So I think I told you guys this before during the COVID time. So in one of the OSCEs where I was the examiner, the patient could not come because patient was diagnosed with COVID. And I volunteered to be the simulated patient so that my colleague could be the examiner. And we managed. So remember, it was an abdominal examination. At the end of the day, after all of those doctors did the superficial and deep palpation, I could not get out of bed the next morning. It was that painful. So you need to think what the simulated patient go through. Be gentle, be kind. They are trained. They are there to help you because a standardized exam is really important to have the best possible simulated patient. And I think I told this last time that a lot of doctors get annoyed when you have a simulated patient that doesn't answer right away and take time, especially when you have an elderly patient. So the elderly patient is there for a reason. Australian population is aging. They're checking to see if you understood that the population is aging and you're going to be kind and gentle. Please be nice to the simulated patient. It really is important. Explain to them in simple language. Eye contact is also very important. So patient safety, be nice to a simulated patient, know your clinical reasoning, communication. And some of you I've heard often saying that, please excuse the jargon and this and that. You don't need to. You can say simple words and you will pass. And the consultation ought to be structured. So imagine, imagine a respiratory system examination. So you walk in there, the patient is sitting there, and you say, okay, I'm going to position you. You made the patient lay down, and then you say, oh, I would like you to check your gait. And then you get the patient to walk because it's irrelevant, but doesn't matter. Patient is walking. Then you say, tell the patient, oh, lie down. And then you say, oh, no, I need to check your back. Move. So if you keep doing things like that, it's not only annoying the examiner, it also annoys the patient. So it is really important that you have the structure. It is 6 to 8 minutes of doing things in a structured manner that will get you across. So while I was studying for my exam, I practiced every single thing. For my introduction alone, I had 7 different introductions. Different scenarios, different introduction. I did not have one standard introduction for all my cases. And that helped me. So I'm not standing there. So when I've read the scenario, I knew what introduction I need to use. So when I walk in there, I'm not standing there and stumbling. I just use the introduction for that station. It's automatically ready. I've practiced it a million times. So it will come very fluently. So 30 seconds, the first 30 seconds are my golden 30 seconds. I literally owned that moment. I showed the examiner I'm competent, I'm good at my work, and I can do this. The examiner will also think, okay, she knows what she's doing. And that helps. So I talked to you about the patterns, every case. So you got to remember there are only about 150 to 160 cases. Now, you cannot pass the exam because you know 150 or 160 cases. You can pass the exam if you understand the pattern and modify your approach accordingly. So if they have given you a patient, now 13-year-old with a headache, you've already done. Now think of a 50-year-old with a headache. How does that change? Or 60-year-olds with a headache. How does that change? So the pattern changes. So every single time when you stand outside, think, what is the pattern? What are they expecting from me? And that helps you enormously. Every single case that I had, I stood outside, I read. I had a rash examination where they said the child is intellectually disabled and she said she was 17 years old, intellectually disabled, and then it said that the child doesn't have any sexual intercourse. The child is not sexually active. And I stood there outside the door thinking, I did not ask that. Why are they telling me that? So there must be something that I need to attend to. Otherwise, why would they say the child is not sexually active? So I thought the only reason could be that I would need to rule out sexual abuse, because if the patient is seroconverting in HIV, you are going to have rashes. And I said that. And that mattered. So look for the pattern and think what the examiner is expecting from me. They're not expecting to hear, is my patient hemodynamically stable in every single station? And that is really not the right way. So there are recurring clinical patterns in all OSCEs, whether it is AMC or CLAB or USMLE, same thing. So you have to know these cases. So chest pain it should be breathing difficulty. I forgot the ing. Breathing difficulty, abdominal pain, headache, dizziness, and your counseling. So if you need to think how you're going to hedge your bet. So think of it this way. If you know your physical examination, if you know your counseling cases, and if you know your psychiatric cases, you would get 5 out of 9 already. You still have 9 more cases left, and out of that, you only need 50%. So if you get 4 more cases, you got your 9. So practice your physical examination, practice your psychiatry, practice your counseling. You will pass. So I usually teach differential diagnosis. So all of the Australian medical students, if you have actually worked in Australia and if you've done your JHO job here, you will know during the rounds, if you ask an Australian medical student for a clinical differential diagnosis, they will say that very quickly. So every single one of them have been trained from day one to use Vindicate as the differential diagnosis. If you Google online, you would find, you just Google Vindicate for differential diagnosis and you will get them. So when you walk into the exam hall, you have a paper for you to write. On one side, you write Socrates, and the other side, you write Vindicate. And then you ask the question. So Vindicate, you look for the differential, and then you ask. This is a very doable exam. So quick identification, the pattern recognition, you start from outside the door. Think of it. Think if it needs to prioritize. Is this a medical emergency? Is my patient going to die in the next few minutes? If it is, I really need to act on it, and then practice it repeatedly. I used to stand in front of the mirror, and all my counseling sessions I practiced in front of the mirror. I would record all of my counseling, then I listen to it, because hearing your own voice actually makes it easier to remember. It's kind of the muscle memory, so you remember those things very much in the exam. You don't have to look for words, it comes automatically. So all of the examiners are expecting the same thing: patient safety, your structure, and how you have made the patient the center of everything. Your simulated patient matters. Make them the center of everything that you're going to do in that 8 minutes you're in the room. Don't move them multiple times when you're doing the physical examination. Wait and listen to them when they tell you something. And when they actually say something, a couple of weeks ago in one of the mock examination with one of the students that I had, and she asked me, "Are you sexually active?" And I said, "No." And the next question she asked me was, "Is there any postcoital bleeding?" You see the problem? Because you're not listening to the patient. And each MC examiner is looking for the same thing. Have you listened to the patient? Do you understand what their concerns are? Are you actually actively participating in this communication between you and the patient? I had the smoking counseling, and I asked my patient between 0 being not at all motivated to 10 being the most motivated, how motivated are you to stop smoking? And he said 0. I said, I hear you. And I know you don't want to hear this, and that is okay too. And all I'm trying to do is that I'll explain a few things for how we can go about it, because who knows, tomorrow you might want to quit and you will know what to do and where to seek help. But what if you have not heard that, and when the patient said that, zero motivation? So you're going to talk and talk and talk and talk, and it annoys the patient, it annoys the examiner because you didn't listen to the patient. So listen. Now, I also teach something called the ma. If any one of you is Japanese, you would know what ma means. Ma in Japanese is the negative space. So every time I asked the patient, I waited for them to reply, and I waited a second or two before I asked the next question. It gave me time to think. The conversation sounded nice. It sounded calm and serene. I did not go there with an AK-47 was shooting all the answers one after or the questions one after the other. So practice that pause. That will also help you. So what are the common pitfalls across the AMC exam? So what do you think the common pitfalls are? You've heard me for the last, let's say, 30 minutes. What do you think the common pitfalls across the AMC exam for almost all of the doctors? If you haven't slept off, you can write the answer. Yep, over relying on recalls, correct? What else? Not understanding the cases, yeah. Anything else? So two people are awake, the rest of you are sleeping. All right, so lack of structure, correct? Time management difficulty, communication. So think of it, we are all doctors. We went through rigorous medical education. We have passed the final exam with flying colors. So why can't we do this exam? We can and we should. So think, I'm not going to do the textbook answers. I'm going to press in there. I'm going to listen to the patient. I am going to focus on making this 8 minutes count. Second thing is your prioritization. Is this so if the patient has assume the patient's blood pressure is sitting at 83/60 or 83/40. Not listen to the patient is correct. So if the patient's blood pressure systolic is under 90 and you still take the clinical history, is there a problem? Because the STEM says take history and management, but the actual physical examination findings somewhere they would have said the systolic blood pressure is under 90. So what is your priority? Are you going to do the fluid recess to keep the systolic blood pressure above 90? Or are you going to continue taking the clinical history because that's what the STEM said? So when you are stressed, you don't see those things. So read the question. So the rule for an OSCE examination is that, stabilize first, you're right, doctor. So rule for the OSCE examination is very simple. When we write an OSCE scenario, I'm not talking about AMC, I'm talking about university. So when we write an OSCE scenario, first thing we do is that, can you read this STEM in under 2 minutes? More than 2 times. So even if the stem looks really, really, really long, don't panic. 2 minutes is 120 seconds. You can read an entire A4 scenario in about a minute. So 2 minutes is sufficient time. And also the scenario is available for you in the room. There's a huge monitor. The whole thing is there. Read it. Think if they gave a particular age, why that age? If it's a gender, male or female, why is that? And think, is my patient stable? Do I need to stabilize the patient first? Always check. If they've given you a physical examination finding quite a lot of normal figures and there's something abnormal, check that. Why is it there? And then act first. So prioritization is really, really important. When you walk in there, you only need 3 differential diagnoses, not more, not less. 3 is more than enough, you will pass. I know you want to give 1 million differential diagnoses. Remember, if you give a differential diagnosis and you have not asked that question to the patient, how is it valid? Is there validity for your differential diagnosis? When we do diagnosis and differential diagnosis, the differential diagnosis means you've asked this question already, but the answer was no, and that is why you have now said this as your differential, not as your diagnosis. So if we haven't asked the question, how can you randomly pick all this differential diagnosis out of the box? That's not possible, right? Okay. So the next thing is your history taking. One of the common themes that I see in pediatric patients, so assume the mother brought a 7-year-old child. The first thing that I hear is that, tell me about the birth history. If the child is 7 years old, are you really interested in the birth history, or are you interested in other bigger picture? Because you're asking for the birth history because you have binds in your head. So you want the birth history, immunization history, nutrition history, I don't know what D is, developmental history, and S, social history, because you've learned that. So you don't see the child is 7. I really would like to know the birth history if the child is 1 year, maybe pushing it to 2. At 3, I would just check to see the developmental red flags for 3-year-old. Has the child met that? But other than that, I don't need to. So the history taking pitfalls is that if you have gone to family history, you or other, like a lot of past history and family history and all of those things, it is clear that you have not taken sufficient history of presenting illness. You cannot do history of presenting illness, past history, family history, all of them in under 5 minutes. It's not possible. So if you have started asking the family history, because those are your fillers. If you're asking them, then you need to think yourself, I have not asked enough questions. Refocus. And the other one, earlier somebody said about having a mental block. And I was taught this by my professor, and it has worked for me all my life. So if you have a mental block, you need to learn to summarize. So summarize something like this, Dr. Karen, Okay, so Karen, you're 34. You have this tummy pain for the last 6 months. It comes and goes, and then you will automatically remember the things that you haven't done. And then you go again. Keep learning to summarize. When you do your role play with your friends, learn to summarize. And the next thing that I hate as an examiner is people going back and forth, back and forth, back and forth. So they are somewhere up in the Socrates, and then they go all the way to drug history, then they come back to Socrates, drug history. So it's back and forth. So the problem is that we have an iPad to mark. Your AMC examiner will have the similar system. They have an iPad to mark. And iPad has only X amount of things on the screen. So while we are marking, and if you go back and forth, I have to scroll down, and then I have to scroll back up, scroll down, back up. It is really annoying. And also, while I'm doing this back and forth, I may not hear what you said. So the unfocused way of questions can be detrimental for you. And the next thing you need to remember are your red flags. The red flags are important if the patient is not stable. The red flags are important if you're going to counsel. So the things that whenever, especially for pediatric cases and normal counseling, like in ulcerative colitis, I would say that these are the red flags you need to look for. And in pediatrics case, if I'm discharging the patient, I would definitely say these are the red flags you need to look for. And the next thing is your eyes, your ideas, concerns, and expectations. This was hard for me personally, and I struggled with it. So I worked something that would work for me, which was that apart from this, do you have any other concerns? And then I asked, do you have any idea what this could be? Expectations you can ask. what are your expectations for this consult? I did not ask because I find it very difficult to do it. But I did ask concerns and I did ask idea. So physical examination has a structure. Check and see if they have asked you to do a complete physical examination or is it a focused physical examination. Both are different. So always when we ask the eyes, okay, so the eyes is asked in between. So you do not do this in the beginning. So somewhere in between, once you have had a lot of your basic history of the presenting illness, and then you want to ask, apart from this, do you have any other concerns? And then you want to ask, what are your expectations for this consult? Or what is your idea for this? But you must ask ideas, concerns, and expectations. And physical examination, remember, is it focused or is it general? And lately, there has been a lot of stations with 3 or 4 minutes of physical examination. That is really, really focused. Do not move your simulated patient multiple times. Do not make it uncomfortable for them. And when you do the superficial and deep palpation, please be gentle. After ruler, yeah, you can ask. Definitely you can ask ice. Ask ice. Make sure you do the ice. And then when you have to ask the physical examination finding from the examiner, so why do we have physical examination finding from the examiner? You have that because now you have asked all the questions. You have come to a diagnosis. Probably you're 90% sure. So you want to know if the physical examination finding correlate with that finding. So you don't have to ask about, so if I assume you have a patient with a swelling of a right foot, there's a swelling. You don't want to ask about, is my patient hemodynamically stable? What are the vitals? All of that. So focus what you want to know. You've already asked all of the history, and now just ask what you need to know. And then go with the case, and then think of your diagnosis, think of the differential. You don't need to go one by one, all of the questions. And also remember, the examiner won't give you multiple, like you can't ask, what is my patient's temperature, blood pressure, SpO2 in one sentence. You need to ask one by one. So use your PFE very smartly and efficiently. And also make sure you do not do the double barrel questions. Every time you ask the patient a question is one thing at a time. And the next thing is that you overtalk because our brain is firing. Remember the ma and the pause? If you don't practice that, you need to do the tube breath. So the tube breath, before you enter, you practice this tube breath. So you take a short breath, you take a very deep breath, and then exhale it all out. So before the door opens, I did this. That calmed myself, and I learned how to breathe. And I learned to smile. And I walked in there with a smile. Every single station. I owned it. It is my patient, my moment to shine, and I was going to pass my exam. There was no place for stress. I am a doctor. I'm a qualified doctor, and I am capable of taking care of this patient, whoever that patient was in the room. That is how I took each of the case. So do not talk too much. In normal life, remember all of our consultants in our own respective hospitals when you were med students? Were they talking all the time? Or they asked the right question, paused, took a few seconds to think, next question. You don't need to talk all the time. And you need to acknowledge your patient's emotion. Do not say, I'm sorry to hear that. That sounds so overrated. I can see that you're concerned. Oh, that would worry. I know, I can see that. Say something like that. Practice something. How are you going to talk? You need to sound yourself. And the last thing you need to think of is your safety netting. The red flags and the safety nettings are really, really important. There's a lot to go through, but you can do this. I believe in you. Remember the textbook reliance? Now, for my exam, I did not study a textbook. You can see behind me, I have 3 murtag. It has become a joke because one is my auntie's. My auntie, at the age of 55, decided to write her AMC exam after she retired in my home country. She wrote her MC1 and MC2 at 55 and passed, went on to become a GP, passed her RACGP fellowship, and worked for another 20 years. So that is her book. Then I have one that was given to me as a gift by a student, and then another one given to me by my sister. So I have 3 muttags behind me. I have not read any of them. I have not read muttag. I cannot read muttag. I don't know. The book doesn't make me happy. So I didn't read any textbooks. I've read the OSCE guidelines. I've read every single guideline for every single illness that is a common theme. Then prioritization. I prioritize every single one of my case. Is it urgent? Do I have time? Do I need to do anything else? And I used my clinical judgment hack, and I was rewarded for it because I did score 7. I refused to rote learn because I am like my constant mantra, I'm a qualified doctor. I don't need to rote learn. So I already talked to you about unfocused questions, missing the red flags, and ignoring the eyes. So don't be vague. If you don't understand or if you don't know, and that is fine, say that I do not know. I genuinely told the examiner when I came to the ECG, I still can't believe I didn't read the ECG. I could not calculate the heart rate. And I told my examiner I became a doctor because I can't do mathematics, and he laughed. Even at that moment, I had a sense of humor. And I knew I'm going to fail, so that was fine too, because there's nothing I can do about it. If my brain isn't working, it isn't working. What am I going to worry about? So I said, okay, I can let go one, and there will still be other cases that I can pass. Over talking, poor listening are bad for you. Ignoring your patient emotion is bad. Inadequate safety netting is also bad. So structured approach to common cases. So you need to know if it is a chest pain in an adult, what is your priority in Australia? If you haven't slept, you can tell me. What's your priority if you have a 45-year-old? Okay, so what is your priority if it is ischemic heart disease? So what would you tell the examiner? So you have a patient there, he has 20 minutes. Yes, the priority is the ECG. Good job, guys. Yes, your priority is the ECG. All chest pain is considered MI until proven otherwise. So tell the examiner, I want to do an ECG. Not that hard, right? So second thing that you need to learn is the tiredness. I personally cannot stand hemi-FADOC. You need to know how to do the tiredness. I prefer the approach asking the patient, define what tiredness means to you. Is tiredness means that you're simply physically exhausted, or you can start doing something but cannot complete it? Is it because you are not able to sleep at night and you're waking up tired, or you're mentally exhausted? So if you can't do anything all day, that is going to be fatigue. I really need to figure out what the cause is. If they can do something and they cannot complete the task, it is going to be a musculoskeletal problem. If they are not able to sleep in the night, it could be medical or it could be psychiatric. If it is mentally exhaustion, I know I need to look at psychiatric cases. So it is pretty easy to do it. And I used a universal framework for every single one of my case. I used Socrates. Even though Socrates was initially for pain, you can actually use it for all of the MC cases. So instead of side, I would usually ask if somebody says that I've been feeling very sad lately. Oh, when did this start? What happened before this? I can do Socrates the same way. And it would work. Time management, I already taught you how to do it. And then reading the stem over and over. And one of the things, I actually have a student who came to my house to learn physical examination because she wanted to pass the exam. She had a knee examination. She had 3 tasks. So all of the so she had 4 tasks. So the 3 tasks she got a 7, and the fourth task was differential diagnosis. She ran out of time, and the bell rang. But from the time you get up to leave out, to walk out to the door, she actually said the differential diagnosis. The examiner will not count anything that you said after the bell rang. If they did, the standardization will not work because everybody gets the same time and we have to follow that. So she got 7, 7, 7, and a 0. And because it was a 0, she failed the station. So always remember, time management is really important. Learn to practice time. Learn when you take the history, take the time. I have used the kitchen timer constantly when I was saying all of my clinical history, and I learned to practice the time. So chest pain, remember I asked you earlier, ECG is first, then the structured assessment, and then you want to ask for help because you're tested at intern level. So make sure you know you are tested at intern level. So you will have to ask for help if there's need, but not everything. So if the patient is not stable, you can stabilize the patient. You have the capacity to do so. So stabilize the patient. So this is the framework I usually use. And I actually use this a lot for my counseling. So what is the problem? Why is this a problem? What will happen if you don't do anything about it? What we need to do for this? And what are the red flags you need to look for? And that worked brilliantly for every single one of my counseling stations. I personally do not like counseling stations. But I put a lot of my time and effort into counseling stations because it is easy. I don't really need to take a clinical history. I can do this. It's so quick, so easy. And it's easy to score. And I wasn't going to let go of my counseling stations. So the X amount of counseling stations, practice them 100%. And I said time management. Read the stem. And when you're sitting in the room, have a glance at the stem again, just to make sure that you have not missed anything. Because you need to meet all of the requirements. Each domain needs to be met. So have the structured responses. All of my responses, I told you, I had 7 different introductions. And because it was all structured, I didn't have to stand there and think, what should I say next? I like a lot of people do this, and I don't like that approach. You say that, oh, from the clinical note, I can see that you have tummy pain. So tell me more about it. And inevitably, the patient would say, what would you like to know? Why don't you start easy? Hi, my name is Dr. Verghese. I'm your doctor today. What brought you to the clinic today? And then the patient would say, I have a tummy pain. All right. When did it start? How did it start? That introduction matter. Practice that. So the practical strategies, you need to know how exams are marked. You need to have clarity. You need to have a logic. Keep the patient in the center. Safety, patient safety is very, very important. Smart preparation. Practice your patterns. Get feedback. And please do role play. You must do role play. So what happens often is that you forget how okay. So remember how you studied in your final year of medicine? You've read all these books. You've understood what you need to, and you went and gave the exam. But that was a written exam. So the knowledge in your head can be translated to writing very easily. AMC exam, it is not. I do. So someone asked, do we need to confirm the name and age of the patient before starting the history? I do. Because clinical error happens often, patient identity is really important. So even though the examiner tells, so when the door opens, the examiner says, you show your lanyard to the examiner, he checks it and he might say, this is Karen, this is your patient, that's okay. Then I say, hi Karen. Or then I ask, or I say, my name is Dr. Verghese, could I confirm your name and your date of birth, please? It takes what, 5 seconds? You can do it. And I do. For every single one of my patients, I asked them. And I got 12 stations out of 14. So it'll work. So practice role play. So I was talking about the exam, that your clinical exam in the final year where you've read all the textbooks, you gave the answer, it was written answer. Or it could have been MCQs, but it was not verbal exam. So AMC exam is verbal. So if you have read all the content, and you have not practiced role play, it is very difficult to translate that because it's the two things. The patient has to tell you, and then you have to ask the next. It's not one thing. You have a question and writing the answer. So practice role play. That will get you across. You need to do two or three mock exams under exam condition. So there are plenty of service providers. Pick one, doesn't matter which one it is, but do the mock exams. You need to do one about 3 weeks before your exam, one about a week before your exam, one about a couple of days before the exam. The last one before the exam, don't worry about your score. It's not for the score. It is just to train your brain how to think in the exam condition, because by the last week before your exam, you would be mentally and physically exhausted. You couldn't wait to finish the exam. So don't worry about your score. Don't even bother checking the score. It is okay. All right. Now the last bit would be to remember your communication. Remember to be logical. Keep the patient in the center. Ensure the safety. So prepare smart. Practice the pattern. So every time stand outside every clinical scenario you get, ask. Why are these information given to me? What am I looking for? Get feedback from somebody who knows what they're doing, and you identify your weakness and improve the reasoning skill. Do timed mock exam. I cannot say enough. Do timed mock exams. I did 6 before my exam. 6 different mock exams. Okay, consistent exam patterns, focus on the core themes. You have core themes and you need to know them, and then get the feedback and you improve yourself. Understand what the exam demands, have a structured approach, practice your techniques. Like I said, you're a qualified doctor, you can do this exam. It is a very doable exam. I'm not one of the smartest doctors on earth. I have seen brilliant doctors, 100 times brilliant than me. Sometimes I'm amazed. So when I'm a teacher, I'm amazed to see how brilliant most of you are. You became a doctor, you passed your exams, you were qualified in your home country, you can do this exam. This is a doable exam. Have faith in yourself. Don't listen to people who says this and that and MC is out to fail. They're not. If I got 2 out of 14 station, I would say MC is rude, they have old patients and all of those, right? If I get 12 out of 14, I can tell you it's a safe exam. You're confident, go take this exam, you will pass. So I do an intensive 3 weeks practice for February exam. It starts coming Monday. It's 2 hours a day, 5 days a week. It'll be 30 hours, and I'll only do 6 doctors, and the fee is 1,950. And what else? And give me a second. I need to show you guys something. That's my document. Not far. Just give me a second. Where's my shape between? So these, you should be able to see my screen. Yep. Okay. These are the common scenarios for OSCE. So these are cardiovascular system. These are respiratory system common scenarios. And this is GIT, neurological, and clinical scenarios in the endocrine system, immune system, then reproductive system, MSK, psychiatry, dermatology, child illness, and then oncology, infectious disease, occupational health. There hasn't come much lately, so we won't know what is next year can hold. And hematology, surgery, counseling. These are the cases that you need to do. And if you have done all of these cases thoroughly, you'll have a fair chance of passing exam, provided you don't get stressed, you're calm, and you're composed. Practice mindfulness, and that will help you a great deal. 1 second, I can't see any comments. Okay, and the last would be that these are usually I create the 3-week schedule. So this will be what you would do if you're on a 3-week schedule. And these are your timetable. So week 1, and then week 2, and week 3. I put insulin administration because I have a feeling they will add it this year. That's about it. And these are my notes. That's separate. All right. I have talked for an hour. You have any questions? Case list? Yeah. You need to log into my Telegram group. And then if you if you follow me on all the social medias, then my admin will give you the case list. Any other question you have? So you need to come to my Telegram. So you look for OMED AMC clinical preparation. So you look for the admin Bhaskar or BSK. And if you message him, he will give you the access to the case list. All right. Do you have any questions? Is there anything I can help you with this? Has your fears eased? Telegram group link. I can. Let me do that first. I don't know how to do that, but let me figure out. Oh, I can actually share the social media. Control C. It should be here. Okay, all the logos came up. I apologize. I don't know why they all came up. But all of my social media posts are there. In the case, if you get the case for example, counseling case that you don't know anything about it and you go blank, you say, yes, you can. You actually can do it. So one of the doctors that I taught, so she actually passed the AMC exam in, let me just turn off my Telegram for a second. I was hoping. Okay, so one of the doctors that I taught, she took my course for 1 month. So she passed her MC1 And then she booked MC2 the very next week, and she was given a spot in 1 month. So there was no way we could have done all of the cases in 1 month. She had no OSCE knowledge, and she actually passed the exam with 10 station, and she had hemochromatosis case as a counseling, and we didn't do it. So what she did is she followed. I taught her that any counseling that you do, even if you don't know, you follow. What is the problem? So what do you think? If you have hemochromatosis, what is the problem? Too much iron? Okay. So too much iron. Why is it a problem? So iron can get deposited in various areas of the body. What will happen if you don't do about it? So she drew a picture of the liver. Yes, she actually drew a picture of the liver on the page and said, this is your liver. And so imagine if it has all the ions deposited, you're going to get cirrhosis. And the simulated patient played along because he understood she had no idea what she's doing. And he said, oh, so that is my liver and that is how it looks. Cool. And she actually passed the exam. She passed the counseling. So remember, counseling cases is what is the problem? Why is it a problem? What will happen if you don't do anything about it? What do we do about it? And what are the red flags you need to look for? That's it. And you will get through all of the counseling cases. Any other questions? Are you spending too much? Any other questions you need the answer? Is there anything else that is bothering you? Or do you have the confidence now that you can do this? Are you still worried? Or you think you can handle this? How important is finish learning the whole? Okay. I personally have not read the handbook. Not once. You can handle. No, don't say I think I can handle it. Say that I can handle it. Why say I think? No, you can handle it, doctor. Have faith. How do we do the running commentary? It's actually very easy. So how I did it, I have a dog. So the entire neighborhood would have thought where I live, they would have thought I've gone mad. Because every morning when I took my dog for a walk, I would say that, okay, good morning, my name is Dr. Verghese. I'm here to do a cardiovascular system examination. This exam involves me looking at your chest, feeling different areas of your chest, tapping on your chest, and listening to your chest with my stethoscope. And for this examination, I would need you to take your shirt off. And then I had two cloths. If you're a male, shirt off. If you're a female, continue wearing your bra. I will need to position you at 45 degrees. See? This is how you do the running commentary. And then now I'm going to do the end of the bed examination, like that. Should candidates join new workshop if they failed previously after taking another workshop? Sure. It is not the workshops that fails you. So first thing, if you have failed the exam before, you have to figure out why you failed. What caused the failure? So the first thing you need to do is go through your exam. Remember what station was it is, and go through the domains where you failed. And then is it the reasoning part? Is it the communications part? What exactly failed you? And that will get you across. Okay, we won't have time to discuss the scenarios. You will need to do the role play. So we go through the cases one by one. So there's not a lot of discussion. So every day you need to do, in 1 hour, we have to do 5 cases. Otherwise, we won't finish all of the cases. So we go through the 5 cases. So each person gets 1 case. practice very quickly, move on. Next one, practice very quickly, move on. So, but everything is either 6 minutes, 5 minutes, or 4 minutes, depends on the scenario. Because if you have exams in February, by now, you should have your knowledge. If you haven't got your knowledge, it'll be very difficult to learn all of that very quickly. We have very little time, and you should be able to get through with 3 weeks of intense revision. But it is hope that you would know things. So physical examination running commentary is actually very easy. Just practice, talk. I use, and the thing is, when I was walking the dog, I had one hand free, and I actually do. I'm going to palpate here. This aortic pulmonary tricuspid mitral, and then I'll say I'm going to use my stethoscope. I'm going to listen for the S1, S2. I'll start with the mitral, then I would do the tricuspid, pulmonary, and then the aortic. And I even added all these things. I'm checking for the apex peak in the fifth intercostal midclavicular. If it is pushed, if it is further away from the midclavicular, it is going to be left ventricular hypertrophy. And I had all of the list causes for LVH. And then I said I would say that I'm going to feel for the parasternal heave. If it is there, it is going to be right ventricular hypertrophy. And I knew what are the causes for right ventricular hypertrophy. So I was going to impress the examiner. I know my stuff, and I was going to show the examiner that I know my stuff. Again, I'm not really one of the brightest doctors. I'm an ordinary doctor that works really hard to pass the exam. Time is your gift. You have time. Do not do a lot of studies about a week before your exam. You just consolidate your knowledge a week before your exam and just rest. You will be physically and mentally exhausted. Sean, if I may ask, when was your exam and what caused your failure? If you're still there, if you can share, August 5th. And do you know what would have been the main reason for the failure? Diagnosis and differential. And what approach did you follow? Did you follow Vindicate? Okay, Socrates would be for your history. And for diagnosis and differential, did you follow Vindicate? I'll find Vindicate for you. Just give me a second. That should help you. Is all med students follow Vindicate. This is the one that I do. So I have sent you guys the Vindicate. Please save it. It's on the comment box and it's worth it. So every single illness you follow the Vindicate. So think, is there any vascular cause? Oh, Sean, it is not your clinical knowledge or your intelligence that would failed. It is just that you did not meet the criteria for the exam. It is not you. Don't get discouraged. You really can't do this exam. Go confidently. Do not take the past burden with you for the exam. Go there thinking that I'm a new doctor in this new hospital. I have 20 patients that I need to take care of. If you find one room empty, that is your rest patient, tell yourself, oh, the patient got discharged. I don't have to take care of one patient. I've only got 19. I did that for every single time I had a rest station because it suited me. So for the Vindicate, remember that you ask immediately, you put the Vindicate down, think, is there a vascular cause? Is there an inflammatory or infectious cause for this? Is there neoplasm, degenerative drugs and deficiency, intoxication, iatrogenic idiopathic, congenital cause? Very rarely I came to congenital. And then autoimmune allergy and anatomy, traumatic cause, endocrine and environment. That works, another one going home. Yes. It you need certain tricks to make you happy. And I joked a lot. I had the patient that fell down from a ladder 10 years ago, and I told her that I'm so glad you didn't die when you had a fall, because otherwise we wouldn't be having this conversation. She laughed, the examiner laughed, everybody laughed. And when I laugh, I feel less stressed, and that helps. I laugh a lot more when I'm stressed too. So laugh. Tell a little joke. You can do this. Have faith in yourself. Don't say that I think I can do it. Say that I can do it and go for the exam. Give your best shot. Always remember your country has given you, wherever you are from, you're qualified in your country. You have a medical degree. You're allowed to treat patients in your country. Transfer the knowledge here. This is a beautiful country to live and work. You will never regret coming to Australia. It's worth. Is there any other questions that I can help you guys with? So at the end of today, I would like you to go home having the confidence that you can do this exam. That it is not a mountain, it is just a small hill that you need to go across. Everybody makes this into a huge mountain. It is not. It is a very, very small hill. You can't. Anything else that I can help you guys with? I passed, so you can. And you only need 9 stations. You can do this. And especially if you are a registered nurse, you can do this. Oceana, OUM grad? Sean, are you OEM? No, are you an OUM graduate? Oceana University. It's okay. All right. So that ends. I'm the grad, but did I know you? Okay, during COVID. Congratulations for doing the RN. And soon, in let's say 3 months, you will be working as a doctor, a junior house officer. Mark my word. You have it in you. You've already done half the battle. One small leap, and you will be there. We need good doctors, and you all are. Believe in yourself. Go and do this exam. Anything else? If not, good luck, doctors. I believe in each and every one of you. Take care of yourself. Bye. Tata. I'll end the session now. Yeah. Bye-bye.